Good morning, everyone. We'll just give it about one more minute before we get started. Okay, I can see a number of people joining, so I think now's a good time to get started. So once again, good morning, and good afternoon, wherever you happen to be. This is our 6th webinar series of updates in COVID-19 clinical practice, hosted by the consortium of USAID, EPIC, RISE, and STAR UCSF. My name's Tyler Law, and I am a member of the Center for Health Equity in Surgery and Anesthesia at UCSF, and an anesthesiologist and critical care physician. I'll be moderating this event today, and I'm very excited about the lineup we have. Today, our topic is the respiratory care of patients with COVID-19 and all of the ways that that's changed. In the care of COVID-19 patients, it can feel like the landscape of evidence shifts constantly, and nowhere has that felt more true than over the course of the pandemic than in the respiratory care of COVID patients. At times, it has felt that every other week, new evidence has arrived that changes recommendation in terms of oxygenation, intubation, aerosolization. Well, now we're several years in, and in fact, a good amount of thought and evidence has been created on the respiratory care of COVID patients. And with that, I'll introduce our speakers, where we'll be talking today over the updates, the WHO respiratory care guidelines, as well as some of the lessons learned in those areas and the evidence where that has come from. So, as I mentioned, the title will be Oxygen Therapies and Delivery Devices in COVID-19, Where Are We Now? I'll begin with reintroducing our two speakers, Dr. Neill Adhikari and Dr. Rich Branson. Dr. Neill Adhikari is an intensivist at Sunnybrook Health Sciences and works at the University of Toronto. He co-leads the Toronto Addis Ababa Academic Coalition in Critical Care Medicine. He's part of the WHO Respiratory Expert Care Panel and co-chairs the WHO Guidelines Panel. Rich Branson is the editor-in-chief of Respiratory Care, the official science journal of the AARC. Prior to becoming editor in 2018, he served as deputy editor for 10 years. So over 40 years as a respiratory therapist, working in research, education, management at the University of Cincinnati, and is currently professor emeritus at the Division of Trauma Care and member of the STAR UCSF Technical Advisory Group. He's over 300 publications and clinical interests in mechanical ventilation, critically ill patients, humidification, and disaster medicine. We'll be joined later by 3 other panelists as well, Dr. Sheila Myatra, Dr. Elisabeth Riviello, and Dr. Kwizera, who I will also introduce when we move to the moderated Q&A portion. And with that, I will turn it over to Dr. Adhikari.
Great. Thanks very much, Tyler, for that introduction. Let me just get my slides up. Okay, so I'm going to be talking to you as a co-chair along with Srinivas Murthy from who's a pediatric intensivist in Vancouver in Canada. We co-chaired the recent WHO recommendations for non-invasive respiratory support for patients with COVID-19. And this is the reference for the full guideline, which is available either from the WHO website or on a website called Magic App, which has some data visualization features. And the objectives of my talk are simply to review the recent WHO recommendations on non-invasive respiratory support for patients with severe or critical COVID-19. Just to remind everyone that COVID-19 is still an active pandemic, showing that data from Johns Hopkins showing that still lots of cases happening, and over the last 28 days, still many cases throughout the world, as you can see in the map on the right. As we talk about the WHO guidelines, just to refresh memories on the classification of disease severity, which is a classification that's now been around since the beginning of the COVID pandemic and developed by WHO. The focus here is on patients with severe or critical COVID-19. So you can see severe patients are patients that are desaturated on room air, that have respiratory distress or signs of pneumonia. Critical patients require life-sustaining therapies or have a clinical diagnosis of acute respiratory distress syndrome or septic shock. And in addition, the relevant population for these particular guideline recommendations include those severe and critical patients who also have a diagnosis of acute hypoxemic respiratory failure, which is not further defined in the recommendations, but it's assumed that clinicians have a common understanding of that entity. So I wanted to spend a few minutes delving into the guideline methods, because I kind of think it's important to have some understanding of how these are developed to understand the outputs. There were research questions which were organized into population, intervention, comparison, and outcome. And these were developed by the WHO with substantial input by the guideline development group or the guideline panel. After the PICO questions were finalized, the WHO commissioned systematic reviews of the evidence. And this systematic review considered evidence both from a direct population, which is patients with COVID-19, but also because of limitations of data for patients with COVID-19 for some of the interventions, it also considered evidence from an indirect population of patients with acute hypoxemic respiratory failure without COVID-19. The systematic review panel conducted a pairwise meta-analysis. This means that the evidence that informed the recommendations were direct comparisons within each trial between intervention A versus intervention B, as opposed to more complicated kinds of network meta-analysis that some of you might be familiar with. The clinical chairs and the methods chair, who is Gordon Guyot from McMaster University, and the WHO team met with the systematic review team to clarify the results, get some additional analyses, and grade the level of evidence, and I'll get into what that means. And then the methods chair and the clinical chairs drafted some recommendations based on the summary findings and presented these to the guideline panel, which then considered the recommendations and decided whether to modify them or approve them. And the guideline panel, in addition, had substantial input into the additional text that was provided with each of these recommendations. So a key point of the systematic review is not just to generate estimates of effect, but it's to consider what the certainty of evidence is in those estimates. And generally speaking, randomized trials start out with a high confidence and certainty of evidence of effects, but for various reasons, the confidence in those estimates of effect can be lowered. For example, if there's risk of bias in the randomized trials, if there's inconsistency in the results, if the population is very indirect compared to the population of interest in the PICO, if the confidence intervals are wide, or if there's evidence of trials that might not be published. And so at the end of the day, you end up with a high level of confidence in estimates of effect, moderate, low, or very low. And you use that to generate recommendations. So you can either make a strong recommendation or a conditional recommendation. And a strong recommendation is one in which the benefits clearly outweigh any downsides. And a conditional recommendation is one where there's a closer balance between the benefits and the downsides, and whether or not to go with the recommendation really hinges on patients' values and preferences, on practical issues, and these are often informed by lower certainty of evidence. So a strong recommendation in favor means that almost all patients would choose to have the intervention, but a conditional recommendation means that many patients would not choose to have the intervention, although a majority of them would. So that brings us to the sources of evidence for these non-invasive respiratory support recommendations. There were 3 interventions considered: high flow nasal oxygen versus standard oxygen therapy, continuous positive airway pressure versus standard oxygen therapy, and non-invasive ventilation versus standard oxygen therapy, from which essentially most of the evidence came from face mask non-invasive ventilation. And you can see here that there's a variety, there's different amounts of evidence informing these clinical questions. For high flow nasal oxygen, there were 4 trials of patients with COVID with a total of just over 1,000 patients, and some more data from patients with non-COVID ARDS. For CPAP versus standard oxygen therapy, only 1 trial in patients with COVID-19 with acute hypoxemic respiratory failure, and about the same number of patients in 4 other trials with non-COVID ARDS. And in face mask NIV versus standard oxygen therapy, all of the data came from patients with non-COVID ARDS. All right, so here's the first recommendation. So this pertains to patients in the hospital, and you'll remember the population: severe or critical COVID-19 plus acute hypoxemic respiratory failure who do not need emergent intubation. The panel made a conditional recommendation for high flow nasal oxygen rather than standard oxygen therapy. And I apologize, I tried to get all of these summary findings tables on one slide. So the way to look at this is that the first column is the outcome, and these were outcomes that were decided in advance as to how important they are. And the critical outcomes for this recommendation are mortality, the need for invasive mechanical ventilation, and hospital length of stay. And another important outcome, but one that wasn't rated as critical, was ICU length of stay. So if you just look at mortality here, you can see that the relative risk for for HFNO versus standard oxygen therapy was 0.87, with confidence interval of 0.66 to 1.13. And this came from 3 trials, 1,000 participants. And if you look at the absolute effect estimates, you'll see here is that per 1,000 patients with this meeting this population criteria, 188 of them with standard oxygen therapy in the trials died, compared to 164 who were given high flow nasal oxygen. And so the absolute effect here is 24 fewer deaths per 1,000 in the high flow nasal oxygen group, but a confidence interval that crosses the null value. And after considering this, the implication is that the certainty of evidence was rated as low, and the plain language summary is that high flow nasal oxygen may decrease mortality. And similarly, for invasive mechanical ventilation, HFNO may decrease the need for invasive mechanical ventilation. There's a bit less uncertainty for hospital length of stay, so HFNO probably decreases hospital length of stay and probably has little or no difference on ICU length of stay. So because of the low certainty evidence for one of the critical outcomes, the recommendation here ends up being conditional rather than strong. For CPAP, so the recommendation for CPAP in hospitalized patients with severe critical COVID-19 and acute hypoxemic respiratory failure not needing emergent intubation, same population. Again, the guideline panel made a conditional recommendation for CPAP over standard oxygen therapy. And the language when conditional recommendations are "we suggest." Looking at the summary of findings tables here, you can see that there is low certainty evidence that CPAP reduces mortality and hospital length of stay, with little or no low certainty evidence that there's little or no difference on ICU length of stay. And again, moderate certainty evidence that CPAP reduces the need for invasive mechanical ventilation. And you may be wondering here, looking at invasive mechanical ventilation, why it's only moderate certainty and with serious imprecision when the confidence interval for the estimate of effect excludes the null values. So you can see both sides of the confidence interval point to benefit. And this is one of these judgment calls in the application of the system of rating the certainty of evidence, where the panel felt that 8 fewer patients progressing to invasive mechanical ventilation per 1,000 was very close to 0, and therefore rated that down as being an uncertain estimate of effect. Again, with mostly low certainty evidence informing this clinical question, the recommendation in favor of CPAP is a conditional one. And finally, for non-invasive ventilation, and you can see here that they're showing a picture here of helmet and face mask interfaces. Again, the panel made a conditional recommendation in favor of non-invasive ventilation versus standard oxygen therapy. And you can see here that all of this is from an indirect population of patients with hypoxemic respiratory failure who do not have COVID-19. And there's moderate certainty evidence suggesting reductions in mortality and invasive mechanical ventilation, and low certainty evidence suggesting reductions in hospital and ICU length of stay. I think Rich is going to be talking about maybe some of these issues further, but the guideline development group created some practical information which is included in the notes to this recommendation, to these series of recommendations around initial flow rates, pressures, and how to titrate these therapies. And there's certainly much more available practical information available on how to use them than are contained in the guidelines. Some key points that emerged when considering this body of evidence were that at the time that this systematic review was conducted, which was several months, which was based on data up until the fall of 2021, all trials were conducted in high resource care settings. And the panel recognized that implementation considerations included considerations around training of healthcare providers, on oxygen consumption, on additional expertise and equipment required for monitoring patients on these treatments, on the needs and expertise required for maintenance of equipment, on how to organize the delivery of non-invasive respiratory support, and of course on the cost, both device costs and personnel costs in terms of training and maintenance of expertise. There were some questions that were considered, but for which no recommendations were made due to lack of certainty of evidence. And probably the most important one is the first. I mean, as a clinician, one would like to see, one would have liked to see the systematic review potentially rank these non-invasive respiratory support options and come up with recommendations about which one is best and potentially under which clinical circumstances. And within the randomized trial data, there wasn't sufficient certainty of evidence to do that. Similarly, there was not enough data to make recommendations on different types of CPAP interfaces that one might consider, or on non-invasive ventilation interfaces. There are additional trials of respiratory support devices that are either ongoing or about to start in resource-constrained settings, which are led by co-panelists on this webinar. So Arise Africa, led by Dr. Arthur Kwizera, and the Breathe trial led by Dr. Beth Riviello will both be expected to add data to contribute to these recommendations in the future. And as more trials become available, the network meta-analysis, which would allow for indirect comparisons of treatments, for example, comparing high flow nasal oxygen to CPAP as an example, that sort of analysis would be informed by network meta-analysis, which may be possible in the future. There's clearly a need for more research on comparisons between devices, on interface comparisons, risks of aerosol generation. I'll just mention briefly that a separate WHO guideline does recommend that each of these devices be treated as an aerosol generating procedure with appropriate respirator masks in use. And the final research need is on the use of these devices in specific populations that generally haven't been included, including children and pregnant women. And I will stop there. Apologize in advance for having to leave the discussion early for another meeting.
Thank you, Dr. Adhikari, for that good overview of the evidence and understanding that it's not always clear interpreting how the evidence goes. Thinking about other things that have shifted and have gone from unclarity to hopefully more clarity as the pandemic has moved on. Professor Branson, would you like to share your slides and tell us about some of the lessons learned?
Sure, hang on a second. Okay, so I appreciate the opportunity and the invitation. A lot of this work is based on a COVID guide that was just authored by a couple of colleagues of mine for the American Association for Respiratory Care, Dean Hess, Jay Lee, and Rich Calais. So I will go through these individual parts and try to be more practical in my approach. So early on, we heard COVID ARDS was different than other kinds of ARDS, and Gattinoni has certainly provided some interesting evidence about early COVID and how ventilation perfusion matching was different. But over this period of time, it seems that the treatment of COVID-19 associated hypoxemic respiratory failure in patients with ARDS who are ventilated remain the same as previously. Tidal volumes of 4 to 8 mLs per kilo, try to keep the plateau pressure less than 30, the driving pressure less than 15. So again, the driving pressure being the difference between the airway pressure and end expiratory pressure. The use of PEEP to reestablish functional residual capacity towards normal, generally 10 to 15 centimeters of water pressure, and also to reduce the effects of oxygen above 60%. Despite early reports that were very popular, especially in the US on social media and in the lay press, the mortality for intubated patients is very similar in COVID-19 that it is to non-COVID ARDS, especially if you compare both groups with sepsis. The famous story was the report in the New England Journal where it looked like the mortality rate if you were on a ventilator was 88%. but 75% of the patients in that study were still in the hospital at the time of the report. So readjustment still gives you a mortality rate in the 30 to 40% range. After mechanical ventilation, there seems to be a signal that there's a risk for post-extubation stridor in patients with COVID-19. Some people have tried to suggest this is because of the viral load present in the trachea. There's a link there. The patients who have higher viral load seem to have more problems with esophageal or such with post-extubation stridor. But it's probably the fact that the patients are on the ventilator for quite a long period of time, and they're more often used prone positioning. And if you have never done it, when you prone a patient, if you measure the cuff pressure, the change in the way the endotracheal tube is in the trachea and the torque on it can result in significantly increases in airway pressure or cuff pressure. And you think, well, how can the cuff pressure change without changing the amount of air in it? And the answer is quite simply because the cuff changes inside the tube, which is the trachea, which of course changes how that cuff pressure is accomplished. So those are a couple things about COVID ARDS that seem to have a signal and suggest we can be pretty confident about. Neill just talked about this issue of aerosol generating procedures. There have been some clarification about definitions, like a bioaerosol is generated from the patient, like during coughing, inducing a sputum, bronchoscopy in a non-intubated patient, and can be potentially infectious. There are medical bioaerosols that are generated during treatment, so aerosol therapy with an updraft nebulizer. And then the source of a considerable amount of study has been fugitive aerosols, those that escape the environment during treatment with medical devices. So if I can kind of share this. So this is from a paper by Jay Lee, who's a respiratory therapist, PhD at Rush in Chicago. And on the left, she's demonstrating the different uses of mitigation as well as the kind of bioaerosols. So on the top left, you have a patient on a regular cannula, a high flow nasal cannula, a face mask, and then a nebulizer. And if you look to the right, most of those procedures are not considered aerosol generating procedures at this point in time, but have been referred to as dispersive therapy. So, and I'll show you a photo here in a second, but when you're on high flow nasal cannula, those patients are no more likely to infect the caregivers because of high flow nasal cannula. Where they become a problem is when they cough or sneeze during their therapy, and then the high flow from either the cannula or the face mask or anything else can disperse the particles further into the room. But for most issues like source control, you put the face mask on the patient if they can tolerate it when you're in the room, as well as wear your own personal protective equipment. Second down there on the left in the middle is the use of a filter on a nebulizer to reduce the patient's exhaled gas into the room. The other one is for pulmonary function testing, again, demonstrating the use of a filter to reduce those problems. On the right, you have the helmet, shows the addition of filters to the inspired and expired portions. Here in the US, we really don't have access to the helmet, except for in a couple of small cases. So I don't have a lot of experience with that. I've worn it when I was in Europe. The use of non-invasive ventilation, the second panel on the right in the middle, demonstrates again the addition of filters can help reduce these problems of aerosols in the room. The bigger aerosol generating procedures actually tend to fall into intubation and bronchoscopy and open suctioning. So again, in any case, there doesn't seem to be a big change associated with the therapies that we were worried about early on. So, and this is a paper by Reinhard Berm from Switzerland, and he's looking at particles in the room with these different subjects. And here you have high flow nasal cannula. You can see there's virtually nothing, no particles in the room. Same patient with a cough, and then high flow nasal cannula and aerosol delivery through the high flow nasal cannula. So there are some differences that occur, but cough by the patient is by far the most concerning aerosolized generating procedure. And again, if the patient can tolerate it when they're on high flow nasal cannula, you can add a face mask to them. And of course, the caregivers need to wear protection. So at this point, our approach has been that high flow nasal cannula is not an aerosol generating procedure. Non-invasive ventilation is not an aerosol generating procedure. Nebulizers in particular should be avoided unless it's absolutely necessary, and you should use a filter. Here in the US, a lot of patients get albuterol. Virtually every ventilated patient seems to be getting albuterol. And the general consensus is that it doesn't hurt. This increased risk suggests that's probably not a good practice. And if you look back at it, the only study of albuterol and ARDS was one of the ARDSNet studies that proved patients who got albuterol did worse. So we should probably avoid that altogether. And intubation boxes, which were very popular at first to try and protect caregivers who were doing the intubating, have appeared to increase intubation failure because people think there's, and also lapses of the use of personal protective equipment because people think the box is protecting them. They still wear their masks. Non-invasive respiratory support, Neill talked about, which for me means treatment with CPAP, which is not a ventilation technique. It's an oxygenation support. High flow nasal cannula is not a ventilation technique. But non-invasive ventilation should for sure not be withheld from patients who have a known positive impact, so COPD, because you're worried about aerosolization. Again, the use of filters can help mitigate that problem. I will tell you that when you do use a filter, it can impact the triggering of certain ventilators, so you have to be careful. CPAP was used far more often looking at the literature in the UK and Europe than it was in the US, but has always been an effective treatment of hypoxemia. High flow nasal cannula, as Neill showed, is certainly beneficial in severe hypoxemia. In less severe hypoxemia, the addition of high flow nasal cannula probably wastes oxygen, and you should use standard oxygen therapy. And there are a couple of measurements, the ROX index for high flow nasal cannula and the HACOR index for predicting success with NIV or CPAP. So the ROX index, you use SpO2, FiO2, and respiratory rate. And here is a paper from Broca that looks at what the ROX score is at 2, 6, and 12 hours, and kind of gives you an idea of whether to consider intubating the patient, evaluate the patient in another 30 minutes, or continue monitoring. And that, in the interest of time, I'll just show you this and let you know that there at least is some evidence that we can use this to make sure we don't leave patients on high flow nasal cannula too long who need to be intubated. I think intubation is still empiric. Early intubation in patients with low levels of oxygen requirements certainly isn't recommended. In select patients with COVID-19, if you delay intubation for too long, you can use the addition of non-invasive therapies. But again, my experience, even before there was anything that we called COVID-19, is that non-invasive ventilation, BiPAP, face mask, with patients with a PF ratio less than 150 is uniformly unsuccessful, usually 60, 70% failure rates. And NIV failure and hypoxemic respiratory failure occurs pretty easily or pretty quickly. You don't have to wait a day or 2 days. Generally, if you can't return oxygen saturation to normal, you can't get the respiratory rate to fall and the patient to improve in their comfort in 2 hours, they probably need to be intubated. Prone positioning, I think, was for sure underutilized before we had COVID-19, in part because it's difficult. A lot of people don't want to do it unless they have this special bed, but it can be, and I don't want to say it can be easily done. It can be done with a dedicated team to make sure that it happens by turning patients using bed sheets. There is some evidence that suggests that non-intubated patients, so-called awake prone, can reduce the need for intubation, and most retrospective studies point to that effect. But typically it's the combination of awake prone positioning combined with either high flow nasal cannula or NIV. A recent prospective trial out of Vanderbilt suggests that there are greater complications with awake prone positioning that haven't been seen with retrospective reviews. And it needs to be done as much as the patient tolerates. If it's not at least 12 hours a day, it probably isn't going to be helpful. We saw a lot of oxygen shortages, and I'm sure that in other parts of the world it was more common than it was here in the US, even though places in New York, California, Louisiana had either complete exhaustion of their supplies or near complete, where they had to resort to backup supplies. Strategies for reducing oxygen uses are important. How your hospital is piped has a particular issue here in COVID-19 and surge capacity ICU. The floor that you normally care for the mothers after they've delivered their babies doesn't have the same size oxygen piping that systems do in your ICU. So if you try to create that into your new ICU bed space, you'll find out that you can't run 3 or 4 high flow nasal cannulas from that oxygen system. It causes the alarms in the wall to go off because it's drawing too much flow. And then I'll show you some pictures of how, when you're using a liquid oxygen, how that can actually create an issue for delivery. I think I've only seen it happen a couple of times. And believe it or not, high flow nasal cannula and non-invasive with a leak at the higher FR2s are the largest consumers of oxygen. And in the interest of time, when the pipes come into your hospital, they come in from the outside of the liquid system, they go up or they go sideways, which makes them either laterals or risers. And where the zone valves are and where the outlets are is where there are restrictions and can reduce the flow to your devices and cause alarms. I'm sure you guys are going to have access to these slides after this, but this is just kind of an idea of your typical oxygen therapy devices and how much oxygen they use and what you can get from the FiO2. The expected FiO2. And if you look again, most people can't seem to fathom that mechanical ventilators use less oxygen than high flow nasal cannula, but they do. And anytime you have non-invasive ventilation in the presence of a large leak, you can really burn through your oxygen. So on the top are 4 pictures across the period of the COVID-19 epidemic at the Cleveland Clinic. And on the left, you can see not much had happened in April of 2020. So the icing on the coils that turn the liquid into gas isn't too bad. They got really busy in September. Then it moved over to January. And the thing that can happen is this bottom picture is the ice can actually freeze the regulator that controls the flow going to your hospital. And if it does that, then you'll lose oxygen flow to your hospital completely. So on the right, this is a picture Asha Devereaux from San Diego provided for me. They put up standard sprinkler systems with warm water around their oxygen delivery system to wash the ice off of the coils. Humidification has been interesting during COVID-19. Early on, everybody seemed to think there was not really a secretion problem. Here's a patient on the right. I hope you can kind of see, this is the HME here in green, and then there's a little bunch of secretions in red down at the bottom and the suction catheter. But the other issue is when you're using HMEs, you have to account for dead space. And this is a picture from a paper in Chest by Francois Lelouch, looking at, with heated humidification, the dead space, the equipment dead space that the patient rebreathes is in red. But with an HME, it includes the catheter mount, as you see on the patient on the left, as well as the HME itself. And most of us, or some of us, remember when HMEs were introduced and the average tidal volume in the ICU was 800 to 1,000 milliliters. So having a 60 or 100 milliliter HME was not a problem. In today's tidal volumes of 300 and 400, this can really result in CO2 rebreathing and accumulation. I'm trying to keep on time here. I think I have about 3.5 minutes. Shared ventilation, so more than one patient on a single ventilator. Certainly, if you're going to do this, 2 is the maximum. I've been telling people before COVID-19, there were 5 papers about shared ventilation in the literature, and 2 of them were papers that my colleagues and I co-authored. trying to get the people who wrote the papers about it not to do it, that it wasn't, they hadn't accounted for all the problems. And I think there's been some really elegant literature written about this whole issue from an ethical standpoint. And one of the comparisons is it better to have a lifeboat, a ventilator, with the recommended number of passengers, or do you overload the lifeboat and risk losing everybody? So there's a point at which you have to assume that one patient's going to die without mechanical ventilation, and that having two on the same ventilator isn't going to increase the mortality for both. And I'll just show you, this is from Jeremy Beetler, who I think has the longest reported shared ventilation cases. He did 3 pairs of patients in New York right before he thought he was going to have to do this on a routine basis. And I know this is a little hard to see, but as you go through it, you're looking at the different patients for their different variables: pH, PCO2, PF ratio, minute volume, tidal volume and based on predicted body weight and peak pressure. The first 2, they used an anesthesia ventilator and had all kinds of problems with humidity in the system, which was another lesson learned in COVID-19. And I'll admit that before COVID-19, I had often written in disaster medicine texts that we could use anesthesia ventilators in the ICU, and it would be a great way of doing this. And it turned out to be far more difficult than any of us really believed. But suffice it to say, these patients were on for 48 hours. They all got transitioned back to single ventilators. And Dr. Beetler would tell you that the amount of additional monitoring that it requires to do this makes it not worthwhile, because it requires more intensive care for just those few patients. And you'd be better off trying to use other mechanisms like non-invasive ventilation for invasive ventilator, or CPAP, or high flow nasal cannula. My one comment about I think a great heartwarming story of the COVID-19 epidemic is a lot of people with engineering talent and their own treasure went out to make do-it-yourself ventilators. Again, very noble, but it's a case of you don't know what you don't know. And I think Mike Lipnick was the first person who told me it was, we should have a mantra that if next time we have a epidemic that needs mechanical ventilation, one of the mantras should be, don't make a ventilator for the first time. And none of those, in my experience, have been helpful. The idea of using recirculating devices to save oxygen, so patients, like an anesthesia system, exhale through a CO2 absorber, oxygen conserving devices, these things have all been tested. Picture of the Buzaniak CPAP device on the bottom right. But with recirculating, you change one precious resource, oxygen, for another resource, CO2 absorbent, which isn't as available as some people might think. Okay, thank you. I think I tried to stay on time. So I'll turn it back over to Tyler.
Thanks, Professor Branson. So for now, I will very briefly introduce our other panelists. We also are joined by Dr. Sheila Myatra. Dr. Myatra is a professor of anesthesiology and critical care medicine working at the Tata Memorial Hospital in Mumbai, India. She's the president-elect of the Indian Critical Care Society of Medicine and the chair of the Intensive and Critical Care Society Medicine Committee of the World Federations of Societies of Anesthesiologists, and a member of our STAR UCSF Technical Advisory Group. We're also joined by Dr. Elisabeth Riviello, who has research focused on ARDS, sepsis in low-income countries. She has a particular interest in examining how context impacts critical care epidemiology, interventions, and outcomes, and is leading a randomized controlled trial of high flow versus standard flow in sub-Saharan Africa, and is also a member of our STAR UCSF Technical Advisory Group. We also have Dr. Arthur Kwizera, who's an associate professor of anesthesia and intensive care at Makerere University College of Health Sciences and a staff intensivist at the Mulago National Referral Hospital Intensive Care Unit in Kampala, Uganda, and a member of the STAR UCSF Technical Advisory Group, the WHO Respiratory Expert Panel, and the COVID-19 Interim Guidance Panel. So with that, we're going to start our moderated Q&A, and I encourage everyone to please put any questions you have into the Q&A, use the Q&A function of the chat at the bottom. I can see there's already one Q&A, which we'll get to in a second, after we initially start with our first question. And my first question, I'm going to direct to Dr. Kwizera, if that's all right. Dr. Kwizera, the guidelines suggest that in critical or severe patients not needing intubation, that's those with a respiratory rate of 30 or an SpO2 of less than 90, to go to high flow or CPAP or non-invasive ventilation. Can you comment on whether this recommendation applies to patients who present with these findings at triage before standard oxygen therapy has been applied?
Yeah, thank you, Tyler. Thank you for that question. Thank you for having me. And hello, everybody. Thank you for joining us. Well, that question has to be interpreted with a bit of context. This particular recommendation refers to patients who have who are already on standard oxygen, who actually have acute hypoxemic respiratory failure. So they should have been, or they should be on some form of standard oxygen. In my practice, for me, the way I would see this recommendation, it's really not about where you are, but what level of respiratory support you're going to get. In practice, especially in low-income countries where we have limited oxygen resources, it would be very impractical to start patients on high flow or CPAP directly. We'll definitely have to give them a trial of standard oxygen. You'll also know, having been to parts of Africa, that we don't have standardized emergency departments, triage rooms, and so on. So your typical resuscitation area for a patient respiratory failure may be anywhere, typically will be on the ward. And so that's why you'd have the resources for oxygen therapy. And in a patient who has these parameters, the recommendation focused on patients with severe COVID and acute hypoxemic respiratory failure. So they would already be on some form of standard oxygen. And so for me, I would let this patient be on standard oxygen of up to maybe 10 liters per minute before I apply these recommendations. And that is also subject to the resources that I have available to me. I hope that answers the question. Sorry.
Thanks, Dr. Kwizera. I see there's a few questions in the Q&A, and I think we'll go to those first now, actually. The first question, I think perhaps Professor Branson can answer this. If closed suction is not possible, is there any way to avoid losing PEEP and aerosol generation?
If you don't have a closed circuit suction catheter, there are adapters, kind of like the bronchoscopy adapters, that can go on the end of the endotracheal tube and have like a cross-shaped slit in them. And as you pass through there, it helps to maintain it. But in the absence of that, there's really no, if you're going to take the patient off the ventilator and slide the catheter down, there's no way to provide PEEP, and there's also no way, if the patient coughs, to prevent the aerosol from being coughed into the room. I don't know if anybody else has a different opinion.
Right. I'd just like to add, absolutely, I agree with you. I'd just like to say that what's most important is we're concerned about aerosol generation is essentially for the healthcare worker, the people around. So you can minimize the stuff, the people, and of course, protect the healthcare workers. So if that's done adequately, I mean, even if there is some aerosol generation, it should take care of the problem and minimize the time for suctioning, of course. And I don't think you can avoid, de-recruiting or loss of PEEP in this if you're going to disconnect and not use a closed suction. So that, of course, is the downside of doing open suctioning.
And it's difficult, of course, because these patients need suctioning as a critical component of their therapy. So it's an ongoing balance of maintaining that PEEP, but also making sure that the circuit remains patent and the airways remain patent as well. I'll just highlight that this is an important question that Professor Branson already answered. How long do you give standard oxygen therapy before reassessing for possible high flow or non-invasive ventilation, and his suggestion was 2 hours. And I think the key is frequent reassessment. The more critical the patient, the more frequent the reassessment, if the panel would agree with that as well.
Yeah, I probably should have just waited, but I saw it pop up and I thought, well, it says answer the question now. I think at 2 hours, things have either gotten better or you need to do something new. Now, in 15 minutes, it may become evident to you, you also need to do something new. So the patients need to be observed and if possible monitored. But again, even before COVID-19, our experience was patients who went on an NIV for COPD, for acute exacerbation of COPD, if they didn't get their SpO2 up, if their work of breathing didn't fall, then still have accessory muscle use, those patients are going to end up being intubated, and delaying it is a waste of time.
I'd just like to add that 2 hours doesn't mean that you have to wait until 2 hours, because some of these patients could acutely deteriorate. So I think the key, like Rich said, is to monitor them very closely when they're on any non-invasive respiratory support and look for clinical signs of deterioration. And that should be your cue to consider intubation, whether it's 10 minutes or an hour and a half. I think close monitoring is the key.
Thank you. One question that we have and that I've had discussed before is that the recommendations lack evidence, they said, to make the determination between non-invasive ventilation and CPAP and high flow nasal cannula. And in some situations, more than one of those may exist. How does the panel go about thinking about how to make the determination of which sort of advanced therapy, knowing that the guideline panel specifically tried not to make a recommendation, but as clinicians, we're often forced to make some sort of determination. So how do you think through the selection of those therapies? Doctors, yeah.
I would say in a high income country setting, what we're really doing is looking at each individual patient. And so, for instance, CPAP, it can be very effective at reversing hypoxemia, but it can also be very uncomfortable, or if a patient has poor mental status, it can be unsafe due to aspiration risks. But in a resource variable setting, you actually have to take more into account. Of course, you take into account what you have between the various devices, but also, and CPAP, in fact, regardless of the patient status, does, I think, require more monitoring on a closer basis, and you may not have the staff to do that. But CPAP can provide better reversal of hypoxemia with less oxygen than high flow, depending on the patient. So if your oxygen resources are a bigger deal than your staffing resources, then you might choose high flow. I would say in reality, most resource variable settings don't have all those options just sitting around and they're picking and choosing between them. But if you were, it's a matter of choosing really carefully where are your resource limitations greater, and also what does the patient look like in that case.
Dr. Myatra, do you have any comments on?
Yeah, so again, I agree with Beth. It depends upon not only the resource availability, but also your comfort levels with using the equipment and the devices. But having said that, unfortunately, with COVID, we don't have very robust, randomized controlled trials where we can say, yes, this therapy, one is better than the other. But if you look at the non-COVID data, if you look at, say, for example, data from the LungSafe study and other studies, and you look at patients clearly where the P2F ratio is less than 150, NIV has actually been worse and resulted in higher mortality. You also see that high flow nasal oxygen is better tolerated by the patient. So and when you put a patient on NIV, you see these COVID patients typically have very compliant lungs, and you see the high tidal volume, and we're worried about the PCLE. So my personal preference would be to use high flow nasal oxygen for these patients if they tolerate it. Sometimes a switch to non-invasive ventilation before an attempt at intubation. But by and large, when I would avoid giving non-invasive, and my preference would be more to give high flow nasal oxygen, though there's no very robust data to support this approach.
Thank you. Yes, of course, it'll come down to a lot to institutional familiarity, it sounds like, and the resources available, which are going to be different in every place. One question from the Q&A is on the question of proning, which is quite a difficult task a lot of the times in the best of times, but particularly for morbidly obese patients. What are some suggestions to make it easier for them to maintain a prone position for at least 12 hours a day?
Again, there are some groups that are very positive about awake prone positioning. There are other groups that have, found that the patients don't tolerate it for very long, that they're so sick when they come in anyway. If you want to try to get them in the prone position, you still have to turn them. It's not like they can do it themselves. I think it's positioning with pillows, try to keep the pressure points moving left to right. But some people just, quite frankly, are not going to tolerate it. I don't know if anybody has a secret. I don't have any secrets.
I agree. I just want to make one comment about awake proning. We did a lot of awake proning during COVID, and now the evidence is more in favor of this, even for non-intubated patients. But I think the monitoring becomes even more important when your patient is in prone position, because a lot of times when this patient is prone, you miss monitoring you miss some subtle signs. And I often worry when I used to prone these patients about delaying intubation. And I think they need to be more closely monitored when you do proning in these patients.
Yeah, I think, I agree. With regards to monitoring, one of the tricks we employed was for the awake patient was to get to improve patient compliance, was to teach them the value, especially when proning improved the oxygen saturation. You'd ask the patients, you'd show them the patient monitor when they were proning and when they were not, and they would see the differences. So somehow they picked it up and tended to be more compliant. They tried to also participate in their own care. Not always successfully, but it was something that helped us, especially where you had one ward that had 30 patients and you had only one nurse. So that was we found that helpful.
I think regardless of the resources you have, of course, resources are always important. The physician in charge with any non-invasive therapy, whether it's high flow, standard oxygen therapy, NIV, CPAP by face mask, or with and without awake proning, is you have to make an a priori decision of when you are going to say this therapy is no longer working. And again, in a very high resource setting in an intensive care unit, I've seen times where patients are failing non-invasive ventilation and, it's busy in the ICU and you say, well, let's, after rounds, let's check before we go to lunch. And then something else happens and you say, well, let's check after lunch. And you push these patients beyond where they ought to be pushed. And that's where you start to see this excess mortality associated with some non-invasive therapies as well as awake prone positioning. So I think the key is to draw a line in the sand and say, if this patient doesn't achieve these goals by 10 o'clock this morning, we're going to go from standard to high flow, from high flow to CPAP, from CPAP to intubation.
If I may just add a point, I agree completely. And what we were seeing in the beginning, we were intubating patients very early because we were just looking at the blood gases and we were seeing these very low PO2s. And then over time, we realized that these patients, unlike with non-COVID ARDS, when they have worsening of gas exchange, they also have deterioration. They have deterioration in respiratory mechanics. But we were not seeing that in COVID patients and they were tolerating it better. So our threshold to intubate also started to go higher. Nevertheless, the monitoring really is the key, because even if you're not intubating them with that low PO2s, monitoring for clinical signs of deterioration is very important. And then what started to happen was very delayed intubations. You have somebody who's absolutely gasping and then getting intubated. And then they say, oh, intubating was increasing the mortality. So I completely agree with Rich that you have to have your endpoints, that this is my cue to intubate this patient. And rather than look at ABGs, X-rays, and blood gas we started going purely clinically with the patient. We started looking for clinical signs of respiratory distress, looking at the respiratory rate, looking at the saturation, looking at the comfort of the patient, looking at use of accessory muscles. And this was our cue to intubate the patient, or escalate to the next level, rather than just looking at blood gas. It was a combination of all these things, but we started going more clinically. And if we felt that even if the saturation was maintained, but the patient was tachypnic and using accessory muscles, we would intubate this patient. So I think it's very important, like Rich said, to have clear-cut goals that this is what I want to achieve, and if I don't achieve this, I'm going to intubate the patient, rather than wait for a time when the patient completely decompensates, and then probably it's too late and you won't get benefits of invasive mechanical ventilation in these patients.
Yeah, I would agree with all that. Just to say, agree with all of that. I just, in terms of shared experience, which I'm sure many people on the call have had, COVID really did stretch us a bit. For the same, we were early intubating because we didn't want to put either patients or providers at risk. And then discovered people, in fact, were not deteriorating super quickly. They could hang out on high flow for a long time and do okay. And I think it's made it more difficult to make those judgments. So when somebody is tachypnic and work of breathing is high, then absolutely they need, when that starts, they need to be intubated. But I think what's been hard in COVID, which I really hadn't experienced, at least in large volumes before, was these patients who are extremely hypoxemic, but their mechanics are pretty good and they don't look bad. And then you have to figure out what to do with them. And I'll say, at least at our center, we don't have a good answer. When people look good, they're maintaining oxygenation on these non-invasive methods. People have different practices. And I say that for the group, just in terms of people's experience. I suspect many people on this call have had that experience. And I will say making those decisions is not easy and people do different things.
Right. I just like to add a point. We used to have these patients who didn't need intubation, patients like you're saying, who didn't require an intubation, were static on, say, non-invasive ventilation, but they weren't getting better either. They weren't getting off NIV. And in these kind of situations, it's very important to look for other causes of deterioration. Sometimes it may be a pulmonary embolism, it may be something else that you're missing. So they would say, people would call and say, oh, this patient's on NIV for like 10 days and he's not worsening, that I need to intubate him, and he's not getting better either. So these are just, some practical things that we learned as we manage these patients.
I'd be interested to hear what Mike says. One of the things that's been interesting to me with COVID-19 has been, again, I'm the one with the grayest hair on the screen. I mean, I can remember when we started using PEEP or CPAP whenever anybody needed more than 60% oxygen, because that was toxic and we didn't want to expose the patients to 60% oxygen. And, again, you may be surprised, early on, we would increase the PEEP until the cardiac output fell by more than 20%. And that was the best PEEP, and then we adjusted it by shunt fraction, all this other stuff. But it seems to me with high flow nasal cannula, nobody seems to be concerned at all with giving 80 or 90% oxygen at 60 liters a minute for days on end. And there doesn't seem to be any negative effect. I know Mike's our resident expert on oxygen. Do you have any thoughts about oxygen toxicity in that group? Or Tyler, you're with the same people?
Yeah, Rich, I think it's a great point. It is certainly an issue. Cumulative pulmonary oxygen dose and toxicity is real. Why we're not able to tease that out, why we're not seeing that, is it something that may come with future data? I think it is right to think about it always, if not for oxygen toxicity reasons, and certainly for oxygen conservation reasons, which may have been a bigger issue in terms of overall outcomes. But it's certainly a real phenomena, and I don't think anybody knows why we're not seeing the data yet, but something to keep an eye on.
If I may just add a point here, I agree with Mike, we don't have data, but one of the things I was observing was we start with, say, 100, of course you can't give 100%, it's about 97% FiO2, but subsequently people weren't coming down on the FiO2. So you have to titrate it to your saturation, your target saturation, until we had an oxygen crisis and we started, getting conscious of how much oxygen we were using. People weren't really doing this. So they would start at, and just keep the patient on high FiO2s. So I think it's important that though you may give very high FiO2s initially, you should come down on the FiO2, and just give just enough to meet your target saturation.
Thanks, everyone. I can see that we're just a touch over time, but this has been a really interesting discussion. I think what I'm hearing from the presenters and from the Q&A is that, through the course of the pandemic, there's been a lot of confusion, but if there is one through line that's come through after reviewing all the evidence, is that what we know has worked for respiratory failure patients continues to work, and that's frequent reassessment, paying attention, and not and relying on your clinical skills. And while that's it'd be nice for all clinicians to have a rule and a guideline, nothing replaces the vigilance of that clinician, and that in fact the suite of things that we can use to care for the patient has broadened in terms of these non-invasive therapies. And until we're able to tease out a definite advantage, we know that there are things we can offer our patients in respiratory failure, and anything or many things are better than just oxygen alone. And there's lots of good ways to continue to care for that patient as long as the clinician remains vigilant. And so with that, I think I'll just quickly point out that there was a short discussion on pulse oximeters, a question about how you can know about the different types of pulse oximeters. And there is the openoximetry.org project, which is working to create this online. I encourage you to check this out. So I think that brings us to the end of our webinar. I want to thank our presenters and panelists and all of our attendees for making this such an interesting discussion. And I hope that brought a little bit of clarity to you and your care of the respiratory care of the COVID-19 patient. These slides and recording will be made available on opencriticalcare.org, as will the rest of them. And I want to thank USAID for convening these webinars and this webinar series for us. Thank you very much, everyone.
Thank you.